morbidity and mortality by obviously improving the knowledge. This is the Pnmdp team founded by Dr. Ahmed in 2020. To become a member, you need to clear your FCPS exam and be enthusiastic to work voluntarily. And this is the email address. You can visit the YouTube channel to watch the videos, as well as website to view the calculators and drug monogram links. You can write for us and email at pnmdp@gmail.com. Can become regional representative for 6 months. And for the upcoming sessions, we have a mock long case for which candidates have already registered, and a pediatric infection disease and immunology BCQ test with explanation. Pnmdp interesting case presentation competition. You can also participate in that. Then there is MRCPCH clinical history taking and communication courses coming up in August and September. You can email for registration. And at the end of the session, we will be sharing this link so that you can complete today's survey. Thank you. Dr. Adeel will take over for his presentation now.
Okay, thank you so much, Dr. Anna. I'm going to share my presentation.
Dr. Adeel, we cannot hear you. You're not audible.
Am I audible now? Hello? Hello? Is my voice audible?
Yes, we can.
Can you hear me now? Hello, can you hear me? Hello? Even?
हेलो डॉक्टर अदील,
Hello?
आपकी आवाज आ रही है?
Oh, so, as, as we were just discussing, I'm going to discuss with you how to approach the cardiovascular system. So, the scheme is same as we do in the long case, like first of all, the introduction, consent from the attendant or the patient, please, if you can understand you. And the next is the exposure, and then and then you can sanitize your hand and then sanitize the patient. So the scheme will be same. But there are certain points that you have to quickly go through in the short case. So I will discuss with you those points, and then we'll try to summarize for our findings at the last.
Dr. Adeel,
So
your
this
voice is not clear to everyone.
now it's clear. It's clear now.
It's better to me. I'll ask everyone.
Okay.
Increase the volume.
So now, can you hear me?
Yes,
Clear.
better.
Okay. Thank you. So this is my presentation outline. First of all, the general look and or the appearance of the patient, then the vitals along with the JVP, then the precordial examination, auscultation, relevant examination, and how to summarize the findings. This is most important in the short case because examiner asks you to summarize the findings that you have picked. And in the last, some few examples that we commonly encounter in our short cases. So, first is the general exam. So once you enter the cubicle of your patient, in which you have to do this examination, the first thing is your general examination, the appearance of the patient, which tells you everything. So the uh, first look and the appearance of the patient is very important, and you have to gain information from that. Uh, so, uh, so from the appearance and build of the patient, you have to ascertain whether your child is malnourished or is well built, which will narrow down the differentials in the end, and the conscious level of the patient, whether your patient is cooperative or irritable. Because if the patient is irritable, it means there is some chronic illness or severe illness which is caused CNS hypoxia or heart failure due to which your patient is irritable. Or the next thing is respiratory distress, which will also be there if your patient is in heart failure or if he's having uh, uh, some kind of sick. Then you have to see whether your patient is cyanosed or pink at room air, or is having any dysmorphic facies, or having any IV line or any urinary catheter. So all these findings are very important in the first look of your patient, uh, uh, starting from the appearance and coming and commenting on the IV line at the end. So as we all know that there are some genetic syndromes which are commonly associated with the cardiac heart disease, with the congenital heart disease. Most commonly the Down syndrome. Apart from that, there are other syndromes like Turner syndrome, Noonan syndrome. So by looking at your patient and ascertaining that your patient is having some genetic syndrome, so you or having dysmorphic species, you can narrow down your differential. Uh, uh, you can easily come to the diagnosis at the end. So this is important to identify any dysmorphic species of your patient. So then you have to uh, uh, examine the pulse. So in the pulse, you have to check for the pulse rate for 10 seconds. Then you can multiply it uh, with 6 to ascertain for the 1 minute pulse rate. And then you have to check whether the pulse is regular or irregular. And then the volume of the pulse, the character of the pulse, and radial or any radio frequency. So from all these things, how you can ascertain the volume of the pulse. Uh, uh, this is very important because if you are commenting that your patient is having high volume pulse or low volume pulse or a normal volume pulse, then there must be some identification mark or criteria on the basis of which you are saying it. So if you are palpating the pulse with the pulp of the fingers, the pulp of your fingers, if you are palpating the pulse, and you can easily palpate the pulse with the pulp of the fingers. It means this is a normal volume pulse. But if you have to search for the pulse, then it means that this is a low volume pulse. You have to search for it with the tip of the finger. But if you have placed the fingers of your hand on the pulse, then you can easily make out, you can easily find the pulse without any difficulty. It means the pulse is high volume. So in this way, you can easily ascertain the volume of the pulse. Of the pulse. Like if you are flexing and semi-proning the hand to forehand and then palpating the radial pulse. So by just placing the pulp of the fingers, so it means that the pulse volume is normal. But if you are searching for the pulse, it means the patient is having a low volume pulse. And if you have placed the fingers of your hand on the pulse and it is easily palpable, then it means it is of a normal volume or high volume. So the volume is very important. So this slide is basically showing the summary of all the pulse characteristic. But the most important is low volume pulse, which will denote the aortic stenosis or low cardiac output. The regularity is very important, as we have mentioned in the vitals. That if the pulse is regular, then it means your patient is having no any arrhythmia. But if it is irregular, then you have to think for the atrial fibrillation. And if the pulse is low volume, it means the patient is having aortic stenosis, low cardiac output. If the pulse is high volume or bounding, it means the patient is having PDA or aortic stenosis or anemia, thyrotoxicosis, etc. So these things are important in the pulse. The next is respiratory rate. You have to ascertain the respiratory rate in the initial inspection. So you can check for the respiratory rate for 10 seconds and you can multiply it with the same formula for the pulse rate. And the next is the temperature. If your patient is febrile to touch, you have to check the temperature with the thermometer. Apart from that, you can skip this part. The next is the jugular venous pulse, which is very important in the cardiovascular examination. So how you can check for the jugular venous pulse? Uh, uh, for checking the jugular venous pulse, you have to make sure that your patient is at 45 degrees. So if your patient is having 45 degree angle, then you have to slightly flex the neck of your patient and turn the face of the patient towards the opposite side. Jugular venous pressure is indirectly denotes the pressure of the right atrium. So the vein which you are looking for is the internal jugular vein. Why we are not taking the external jugular vein for the jugular venous pressure? It is superficial, but it is very tortuous, and it is not directly depicting the right atrial pressure. So we are taking the internal jugular vein for it. So how you can identify the internal jugular vein? There are basically two heads of the sternocleidomastoid muscle, and a triangle is formed by the two heads and the clavicle. The base is formed by the clavicle, and the two heads form the anterior and posterior borders. So in between this triangle is the internal jugular. So by making this position, you can easily identify the internal jugular vein, and if the jugular venous pressure is high, you can easily make out the jugular venous pulse. You can easily identify the jugular venous pulse. So once you have identified the jugular venous pulse, you have to differentiate it with the carotid pulsation, because it is also somewhere in the same area. However, the carotid artery is just medial to it, but you can misdiagnose it as raised AVP. So how you can differentiate it? So we'll discuss in the next slide. First of all, how to ascertain the jugular venous pulse and the pressure. So, as your patient is lying at the 45 degree, you must have two scales with you. First of all, you have to identify the manubrosternal joint. So once you have identified the manubrosternal joint by tracing your finger downwards from the sternal angle, once you have identified the manubrosternal joint, you have to place a scale or perpendicular to it, and then another scale horizontal to it, which will coincide with the jugular venous pulse. So the measurement which will come uh, on the vertical scale will be the jugular venous pulse. Jugular venous pulse. And when you will add 5 centimeter to it, to the jugular venous pulse, it will become the jugular venous pressure. So as it is solved in this equation, like your jugular venous pulse is at 3 centimeter, which we have ascertained with the two scales. You have to add the 5 centimeter. Why we are adding 5 centimeter? Because right atrium is 5 centimeter below the manubrosternal joint. So by adding these two, we'll get uh, 8 centimeter of water, the jugular venous pressure. We'll get the jugular venous pressure. So if it is more than 7 centimeter of water, it means your jugular venous pressure is raised. It will indirectly denote your right atrial pressure is high, and means your right ventricular pressure, which will indirectly denote the right ventricular pressure. So high right ventricular pressure will raise the right atrial pressure, and which will ultimately raise the jugular venous pressure. So these are the waves which we commonly see in the JVP: the A wave, C wave, X descent, V wave, and the Y descent. So A wave will denote the atrial contraction, X wave, X descent will denote the atrial relaxation, C wave will denote the tricuspid contraction, and V wave will denote the venous filling of the right atrium, and Y wave will denote the atrial empty. So in tricuspid regurgitation, the V wave will be increased. So we were talking about the comparison of the jugular venous and carotid pulse. So this is basically the table in which there are some differentiating points between the two. You cannot palpate the jugular venous pulse. Once you see the pulsation in the neck and you will try to palpate it, it will not be palpable. So that pulse will be jugular venous pulse. But if you can easily palpate that pulse, it means this is carotid pulse. Another thing is pulsation will be obliterated by the pressure above the clavicle. So if you will compress the base of the triangle, which we have discussed in the previous slide, So the pulsations will be obliterated. While this will not be the in the case of carotid pulse. So when occluded, it fails from the above, not easily occluded. This point can be missed, but we'll come to the next point. That is the level of pulse wave decreased on the inspiration and increased on the expiration. As we all know that in the inspiration, the venous return to the heart is increased because of the negative pressure that is generated in the lungs. So because of that increasing venous return to the heart, the pulse wave will be decreased because the venous return will be towards the right atrium. But there will be no effect of respiration on the carotid pulse. Usually there are two pulsations, as we have discussed, that there are two descents and two upstrokes, while in the carotid pulse there is just one pulsation. The pulsation sometimes move prominent with increased abdominal pressure. Like if you are doing the hepatojugular reflux, the jugular venous pressure will be increased. So these are some differentiating points. Another point can be if you will ask your patient to sit or stand, the jugular venous pulse will disappear because of the gravitational venous return towards the heart, while the carotid pulse will remain there. So these are some differentiating points. Okay. After doing the vitals, we'll come to the precordial examination. So in the precordial examination, the first point is the inspection. So in the inspection, first of all, we have to look at the chest wall, the symmetry of the chest wall, whether there is any bulge or any pectus carinatum, excavatum, or any other chest wall deformity. Apart from that, you have to comment on the scars, the visible pulsations, and the visible veins. All these points are important in the inspection. As it is shown in this picture, that your patient can have barrel chest, means increased AP diameter, or kyphoscoliosis, pectus excavatum, and the carinatum. You have to comment on these in the inspection. The next are the scars. If your patient is having a midline sternotomy scar, what does it denote? It denotes that your patient had total repair or total correction of the congenital heart disease. Means whatever the congenital heart disease was, he might have undergone a total repair procedure for it. If your patient is having anterolateral or posterolateral thoracotomy scars, it means that your patient might have some palliative surgeries like a Belloc toxic shunt or pulmonary artery bending or coarctation repair or PDL ligation. We do these surgeries through the posterolateral thoracotomy scars. Apart from that, if your patient is having if your patient is an adolescent and having a scar mark at this area left upper sternal border, it means your patient had some pacemaker implantation. So this was all about the inspection uh, uh, and the scars. Another important point in the inspection is the pulsation. So you have to identify any visible pulsation in the chest, and then you have to interpret it immediately. Like if your patient is having epigastric pulsation, it means that right ventricular pressures are high, and your patient is having epigastric pulsation because of the increased right ventricular pressures. So right ventricular pressures can be increased either due to pulmonary hypertension, or it can be high due to pulmonary stenosis. So both can be real. Apart from that, if your patient is having left peristernal pulsation, so it can be due to right ventricular enlargement. If the pulsation is there at the pulmonary area, means left upper sternal border, then it can be due to pulmonary hypertension. If it is in the suprasternal or carotid area, means your pulsation is there, so it can be due to aortic regurgitation, which and the sign is called as Corrigan sign. So basically, the area of pulsation is important in the precordium. So if you are finding any pulsation in these areas, then the differential can be. So now coming to the precordium. So before palpating your patient, don't forget to warm your hand before touching your patient, because there are marks for it. So in the palpation, you first have to ascertain the epic speed. The next, whether it is displaced or undisplaced. And the third part will be the character, uh, whether it is of normal character, whether it is forceful, sustained, or ill-sustained. So basically, these three components uh, will come in the epic speed. So if you are explaining to the examiner about the apex speed, you have to tell whether the apex speed is displaced or undisplaced, and then you have to proceed forward. So if your patient's apex speed is undisplaced, means the apex speed is at its normal position, that is 15 intervals space at mid-clavicular line. So along with the congenital heart disease, so what can be the possibilities? So they can be ASD, they can be aortic stenosis, they can be pulmonary stenosis or mitral stenosis. In all these things, the apex speed will be undisplaced. So the next point will be okay. Now there are some differential for the displaced apex speed. If you are finding that your patient is having displaced apex speed, means the apex speed is at 6 intervals space at anterior axillary line. So what will be the differentials? So all the volume loading conditions will be there in the displaced apex speed differential, like the mitral regurgitation, aortic regurgitation, large VSD or large VD. All these will come in the differential of the displaced apex. So next will be the character. So first you have to ascertain whether the apex speed is undisplaced or displaced, and then you have to check the character of the apex speed. So but before saying the displaced, how you will count the intercostal spaces? So like we have done in the JVP, that we have to palpate the sternal notch, and then we have to trace the mandibular joint. So just opposite to the mandibular joint will be the second intercostal space. You have to count the intercostal spaces subsequently, and then wherever you are finding the maximum lower and outermost part of the maximum impulse, so that will be the apex speed. Means the lower and outermost part of the pulsation will be the apex in the chest. So in this way, you can easily ascertain whether the apex speed is displaced or undisplaced. So after that, you have to comment on the character, whether the character is normal, if it is tapping or forceful. Normal character means that the pulsation just touches your finger and not lifting it. It goes away. But in the tapping character of the apex speed, the first start sound will be palpable. Means tapping means first start sound is palpable, like in the mitral stenosis. You will find the tapping apex speed. The next is the forceful apex speed. What does it mean? It means your finger is lifted because of the forceful contraction of the heart. You can find the forceful contraction in the pressure overload conditions, in the volume overload conditions. So how you can differentiate between the two? If it is forceful, the apex speed is forceful, and it is sustained, means you are palpating the carotid pulsation, and then in the carotid pulsation, in the systole part, if your finger is lifted for more than 2/3 of the systole, means in the most of the part of the systole, it is sustained apex. But if it is uh, not lifted in most of the part of the systole, means less than 1/3 of the systole, it will be ill sustained apex. So in this way, you can differentiate between the pressure overload and volume overload conditions. So if your patient is having a forceful apex beat, means your finger is lifting and it is lifting for more than 2/3 of the systole. It means your patient is having a forceful and sustained apex beat, and your patient is having aortic stenosis or hypertrophic obstructive cardiomyopathy. But if your patient is having a forceful and sustained apex beat, means your patient is having volume overload condition, means aortic regurgitation of heart rate. So the next will be the parasternal heave. So after locating and locating the apex beat, you have to check for the parasternal heave. You can check for the parasternal heave either with the with your palm or with the left lateral edge of your hand. So both methods are fine. So by checking the parasternal heave, it will denote the right ventricular pressure. If the right ventricular pressure is increased, then there will be a parasternal heave. So in which condition right ventricular pressure will be increased? It will be increased in the pulmonary hypertension or pulmonary stenosis. Uh, Next is thrill. So for thrill, you have to make a Z technique. Means you have to place your palm at the in the apical area and in the left lower edge of the chest, then at the left parasternal area, and then at the right upper and left upper sternal points. So in this way, you can easily check for the thrill in all the four areas, and you will not miss it. And uh, one thing you have to check, you also have to check the suprasternal thrill. You have to, uh, like you are palpating the trachea, you have to place the two fingers on the trachea, and then on the carotids. Uh, uh, you will easily feel the thrill. If the thrill is there, means the carotid thrill is there, it will denote the aortic stenosis, severe aortic stenosis. So first you have to make a Z technique, and then you have to check the suprasternal thread. So this will complete the palpation part of the recording. So if the thrill is there in the suprasternal area, it will denote the aortic stenosis. If the thrill is at the apical area, it will denote the mitral regurgitation. If it is at second intercostal space, it will left upper sternal border, second intercostal space, it will denote the pulmonary stenosis. And if it is at the left lower sternal border, that is at the fourth intercostal space, it will denote the small VSD. So these are basically the differential of the thread. So here you can see that they have mentioned that you have to check for you have to localize the pulse with your pulp of the fingers. That you have to localize the apex beat with the pulp of the fingers. You have to check for the thrills with the metacarpophalangeal joint. You have to check for the heave with your palm. Okay. So next is the auscultation. So so in the auscultation, what we do is we make a common mistake that we jump right away to the murmur. We don't have to jump right away on the murmurs. We first have to mention how is the first heart sound, how is the second heart sound, and then we have to mention the additional sound, that is the murmur. So this is a mistake which we have to avoid in the exam. So we know about the areas, the mitral area, tricuspid area, aortic and pulmonary area. Sorry, I'm not taking the questions. I will take the question at the end. So these are the four areas. So we have to auscultate all these four areas, and we know that the where is the first rush sound? First rush sound is due to the closure of the atrioventricular valves. Means it is produced with the closure of the mitral and tricuspid valves. While second heart sound is due to the closure of the pulmonary and aortic valves. So first heart sound will be more audible in the mitral and tricuspid area. You can easily appreciate it. And the second heart sound will be easily appreciated in the left upper and right upper sternal borders. So once you are auscultating the patient, you have to keep the thumb or the fingers of your hand at either the carotid of your patient or at the brachial pulsation. You have to feel arterial pulse along with the auscultation. This is very important because you cannot comment on the systolic murmurs or diastolic murmurs without palpating the arterial pulsation. So you have to auscultate side by side with the palpation of the uh, arterial pulse. We all know about the grading of the murmurs. Grade 1 is the very faint murmur, grade 2 is soft murmur, grade 3 is moderately loud without any frill. What does it mean? Moderately loud. Why we are saying it is moderately, how we can say it is moderately loud? We have to compare the murmur sound with the first and second heart sound. If it is of equal intensity with the first and second heart sound, it will be a loud murmur. But if it is of low intensity as compared to the first and second heart sounds, it will be a soft one. So in this way, we can comment on it. And if it is a loud murmur along with a thrill, it will be a grade 4 murmur. If you have placed the rim of the diaphragm of your stethoscope at uh, uh, the murmur side and you can hear the murmur, it means it is of grade 5. But if you have brought the diaphragm of your stethoscope very near to the chest wall and you can hear the murmur, but it is not touching the skin, and you can hear the murmur, it means it is of grade 6. Same goes with the diastolic murmurs. So this diagram will make life easier for you. If you are auscultating a murmur and you have to ascertain uh, uh, where is the maximum intensity of the murmur. You will hear the murmur in all the areas, but you have to identify where is the maximum intensity of the murmur. If your murmur is at mitral area, means the apical area, then it will be most probably be the mitral regurgitation or mitral stenosis murmur. If it is of maximum intensity at the left sternal area, it will be of VSD. But if it is of maximum intensity in the left upper sternal border, then it can be of pulmonary stenosis of PTA. And if it is in left upper sternal border, it will be of aortic stenosis or aortic regurgitation. So you first have to identify where is the maximum intensity of the murmur in all the 4 areas. Then you can narrow down your differentials. And you have to correlate all the findings along with it. You cannot diagnose a congenital heart disease only and solely on the basis of the murmur. You have to correlate all the findings. If your patient is having a displaced apex beat and you are finding a murmur in the mitral area which is radiating towards the axilla, then you can easily correlate it as a volume loaded condition, and it will be of MR. So likewise, you have to correlate all the findings along with the murmur. So once you have identified the murmur and you have correlated it with the arterial pulsation and you have ascertained that it is a systolic murmur or diastolic murmur, then there are certain maneuvers which we have to do to differentiate it from the other murmurs, like the inspiration. In the inspiration, right-sided murmurs are accentuated, and in the expiration, left-sided heart murmurs are accentuated. So you have to check for the accentuation of the murmur to differentiate it from the other murmurs. Like I will give you a small example. If you have identified a murmur in the left dorsal border and it is of pansystolic nature, then the differential would be a tricuspid regurgitation or a VSD. So how you will differentiate between the two? So as we know that the right-sided murmurs are accentuated in the inspiration. So if you will ask your patient to take a deep inspiratory breath, then the TR murmur will be increased, while the VSD murmur will remain unchanged. So in this way, you can easily differentiate between them. So this is very important to do these maneuvers to differentiate different different etiologies of. So the next is position change. If you are suspecting that your patient is having aortic regurgitation, then you have to do this maneuver, like you have to ask your patient to set up and lean forward, and then you have to ask your patient to take a deep breath and expire, and then hold his breath to easily identify the aortic regurgitation. So you have to do this maneuver for it. But if you are suspecting a mitral stenosis in your patient, then you have to do a left lateral. But if your patient is having a VSD murmur, you don't have to do all these maneuvers. Or if your patient is, if, if your patient is a cyanotic child, you are not supposed to do all these maneuvers. You can skip this part, the position change part. Okay. There is some differentiating. Okay. So we were at this slide, the radiation versus transmission of murmur. So we have to check for the radiation and the transmission of murmur by so, so what is the basic difference between the two words, the radiation and the transmission? Radiation is basically we use this word when the maximum um, murmur sound will be at one area and will fade subsequently in the other area. It will be a radiation of the murmur. Like in the mitral regurgitation, you will hear maximum intensity of the murmur at the mitral area or the apical area. It will radiate to the axillary area, but it will not be of same intensity that you have heard in the apical area. So it will be basically radiation of the murmur. But if you are hearing the same intensity of the murmur in all the areas, it means it is basically transmission of the. So, so there is basically a small difference between the two words. So if the murmur is radiating towards the carotids, it means your patient is having aortic stenosis. But if it is radiating towards the axilla, it means your patient is having mitral regurgitation. If it is radiating towards the back, then your patient might have pulmonary stenosis, coarctation of aorta, or the patent ductus arteriosus. Okay, this we all do. We forget to auscultate the back. Uh, don't forget to auscultate the back. This is a very important message because you have to check for the murmur radiation. You have to check for the basal crepitations. You have to palpate the spine, which we have discussed in the inspection part. That you can inspect the chest from anteriorly, but you have to palpate the spine from the back because if your patient is having a scoliosis or kyphosis, you can miss easily from anteriorly chest. So you have to palpate the spine and you have to check for the sacral edema as well. Because if your patient is bed bound and you can easily miss sacral edema if you will not palpate for it. So you have to check for it. So while you are auscultating, you will auscultate from the precordium, and then you have to come to the back for any radiation, basal crepitations. You have to palpate the spine and then the sacral edema. And then in the next part, you have to check for the stigmata of infective endocarditis. This is very important. You are not supposed to end your examination after auscultating the just the precordium. You have to check. Your examiner will tell you to examine the precordium at relevant. So in the relevant part, uh, all these things come. You have to check for the stigmata of the infective endocarditis. Means you have to check for the oscar nodes by just taking the the hand of your patient, uh, just palpating the fingers of the patient and just touching the pulp of the fingers. There will be a tender pea-sized nodule. Then it means your patient is having oscar nodes. If they are the edematous lesion in the hands or the soles, then the patient might have UV lesions. You have to check the nails of your patient for the splinter hemorrhages. You have to check for the oral hygiene. This is very important. You have to check the dental hygiene and the oral hygiene because it can be a precursor of infective enteritis, a predisposing condition for the infective enteritis. You have to check for the anemia in the conjunctiva. You have to check for the splenomegaly in the abdominal examination, and then you will come to the lower limbs for the arthralgia or arthritis. You have to check the temperature, and then you can move the leg of your patient by asking your patient whether he's having any pain in the legs, and then you can move the legs on. Uh, then you can do the joint examination, and then in the last pediatric. So all these are very important, and you have to do it in the a schematic way. Like you have to start from the hand. You have to check for the osseous nodes, chainway lesions, splinter hemorrhages, uh, then the pulse of your patient, and then you have to check the subcutaneous nodule at the extensor areas, and then you have to check the JVP. Then you can come on the head and palpate the head for any you, you have to check the head for any scar marks, for any abscess drain or previous surgery. Then you have to come to the eyes to check for the jaundice and anemia. Then you'll come to the ears for any ear discharge. Uh, uh, then come to the oral cavity examination, and then the abdominal examination, then the lower limb examination for joint, for arthralgia, arthritis, and for the pedal. So this will complete your examination. You will not miss any point. Okay. So, but this is very important. If you are and if you have found a murmur of mitral regurgitation or mitral stenosis, then don't forget to do the signs of Korea, because we all miss this part. We just auscultate the murmur, and then we are satisfied that we have done everything. But we have to check for the stigmata of the infective endocarditis, as well as we have to do the signs of Korea. We can do these signs while doing our examination. Like if we are palpating the hand of your patient for the osseous node JNV lesion, then immediately you can ask your patient to extend your hand, to extend his hands. You can immediately, while doing the oral cavity examination, you can ask your patient to toot the tongue. In this way, you can check for the darting tongue. You can extend the you can ask your patient to extend the hands above the head. You can ask your patient to hold a pen, or you can communicate with your patient during the examination to check for the articulation. So in this way, you will do all the examinations while doing your routine examination. You will not miss anything. You have to check for the subcutaneous nodule while doing the spinous examination. If you are palpating the spine, you can also palpate for the subcutaneous nodules. If you are coming from the hand to the neck examination, you have to check for the subcutaneous nodule in the elbow area as well. So if you are examining the joint, you have to check for the subcutaneous nodule at that area as well. So it is just a schematic approach. You have to keep in mind all these points you will not miss during the examination, and you have to tune yourself so that you do all these maneuvers within 5 minutes. So things to do at the end of the examination: you can offer the patient to walk at the end of the examination. This is very important if your patient is a cyanotic patient, to check for any neurological deficit. You are not supposed to do complete neurological examination of the patient, but you have to check for any neurological deficit. So you can ask your patient to walk, and in the end, you have to offer to check the blood pressure, height, and weight of your patient, and ask to plot on the centile charts. You have to mention all these things to the examiner. You are not supposed to do these things in the short case. Don't forget to thank your patient and patient attendant and cover your patient in the end. So this is very important because we usually don't do this. and our marks get deducted. So this was all about the examination part. So then at the end, your examiner will ask you to summarize your findings. So I will give you some paragraphs which you can remember and which you can just practice, and you can easily fit in your findings in this paragraphs in these paragraphs, and you can easily summarize the findings. So you can summarize your patient finding in this way, like my patient is dash years of age, he's conscious, cooperative child, lying comfortably on bed, having no dysmorphic species, not in obvious respiratory distress, and is pink or cyanosed at room end, whatever the finding it is. His pulse rate is dash beats per minute. It is regular, normal volume and character. The respiratory rate is dash per minute, and GVP is raised or not. Coming to the periodic examination, there are no scar marks, visible pulsation, veins or chest deformity seen. His apex speed is undisplaced or apex speed is displaced at dash interval space at mid-clavicular line or at the line or whatever the displacement is, and is of normal character. Or if your patient is having coastal apex speed, then you can add it here. There is no personal heave or thrill present. His first and second heart sounds are normal. So this is important. We are not supposed, we should not jump directly on the murmur. We have to mention how is the first and second heart sound. So his first and second heart sounds are normal. There is an additional murmur of 3 by 6 or 4 by 6, whatever the murmur is, whatever the grading of the murmur is, at best heard at dash area, accentuated on the inspiration and expiration, and leaning forward or left position and predating to dash position. So this will completely explain your pre-cordial examination findings. There are no bivasal crepitations, sacral or pedal edema, oral hygiene is fair or poor, and no stigmata of infective myocarditis and no signs of chorea present. If your patient is having MR or MS, you have to mention this at the end, that there are no signs of chorea. So this will completely summarize each and every finding of your patient. So this was all about the short case of CVS. So now I'll take your questions. So you can ask whatever is in your mind. If anything is not clear, you can ask from
Someone has asked in the chat box how to differentiate normal and high volume pulse.
Okay. As I have told you that if the normal pulse is with the tip of the finger. If you have semi-prone the hand of your patient and and slightly flex the hand of your patient, and you have palpated the radial pulse with the tip of the fingers. You you just have to apply gentle pressure. So if you are and if you can palpate the pulse, it means the pulse is of normal body. It means it will be palpable with the tip of the finger. But if you have placed the pulp of your fingers at the pulsation area, and then you can easily make out the pulse, it will be of high volume. But if you have to search for the pulse, it will be of low volume.
There's a question, may we check brachial pulse for first and second heart sounds?
Yes, you have to keep your hand at either the carotid area or the brachial area. It depends on you and your practice. You have to keep your hands on this area, and then you have to start auscultating the uh, the first and second heart sound, and then the murmurs. So make it a habit, so you will not miss it.
सर अगर हमें एक पैन सिस्टोलिक मर्मर लेफ्ट लोअर स्टर्नल बॉर्डर पे मिल रहा है तो हम उसकी डीडी में वीएसटी के साथ ट्राइकस्पिड रिगर्जिटेशन तो बोलते हैं, क्या हम पिंक टॉफ रख सकते हैं उसकी रेफरेंशियल में?
मैं आगे एग्जांपल्स में भी बताऊंगा कि टॉफ के अंदर जो है हमें वीएसडी का मर्मर नहीं मिलता. उसका रीजन ये है कि राइट
सर पिंक
वेंट्रिकल और
टॉफ
लेफ्ट
है, जैसे मतलब उसमें तो फिर भी मिल सकता है ना अगर ग्रेडियंट कम है आरवीओटी के अक्रॉस।
हाँ, अगर ऐसा वाला टॉप है कि जिसमें आरबीओटी का ग्रेडियंट ही नहीं है या बिल्कुल मिनिमम ग्रेडियंट है और लेफ्ट टू राइट शंट है एट द बीएसडी, तो उस केस में ये है कि मतलब तब आप रख सकते हैं, लेकिन डिफरेंशिएटिंग पॉइंट विल बी इंस्पायरेशन, रेस्पिरेटरी वेरिएशन होगी इसमें, ट्राइगोस्पिडिक वेजिटेशन में आपके इंस्पायरेशन में मरमर इंक्रीज हो जाएगा, क्योंकि बीएसडी में मरमर जो है इसमें अनचेंज रहेगा। तो बेसिकली अगर लेफ्ट वेस्टर्न बॉर्डर पे एक मरमर आ रहा है विद थ्रिल, तो आपने स्मॉल वीएसडी ही रखना है उसके मतलब डायग्नोसिस। और डिफरेंशिएट टीआर से आप ऐसे करेंगे विद टी इंस्पिरेशन को, अगर एक्सेंचुएट हो रहा है इट मींस इट इज ऑफ टीआर। क्लियर हुई है? ये पॉइंट क्लियर हुआ?
जी सर, थैंक यू।
Any other question?
Sir, kindly can you elaborate Z technique?
बेसिकली इसमें ये है कि अगर हम एंटीरियर चेस्ट को पैल्पेट कर रहे हैं तो हमें एक हैंड अपाइकल एरिया में रखना है सबसे पहले हॉरिजॉन्टली, ताकि हम अपाइकल एरिया और लेफ्ट स्टर्नल बॉडी यानी माइटर और ट्राइगोस्पिड एरिया को कवर करें। फिर उसके बाद हमने लेफ्ट स्टर्नल बॉर्डर पे हैंड रखना है वर्टिकली, ताकि हम ट्राइगोस्पिड एरिया और लेफ्ट अपर स्टर्नल बॉर्डर यानी पल्मोनरी एरिया को भी कवर करें। फिर हमने पल्मोनरी और एओर्टिक एरिया पे दोबारा से हॉरिजॉन्टली अपना हाथ रखना है, ताकि एओर्टिक एरिया और पल्मोनरी एरिया को कवर करें। तो इस तरह से आपकी जेड एक बन जाएगा जिससे आप सारे एरियाज को कवर कर लोगे। और इसके बाद फिर आपने सुपरस्टर्नल एरिया में भी चेक करनी है, जो कि हम मिस कर देते हैं, क्योंकि अगर सुपरस्टर्नल एरिया में आपने मिस कर दिया और सपोज एओर्टिक स्टेनोसिस हुआ आपके पेशेंट को, तो आप कैरोटिड थ्रिल को मिस कर देंगे, जो कि एक इम्पॉर्टेंट फाइंडिंग हो सकती है। आपने जेड टेक्निक पहले बनानी कि अपने हॉरिजॉन्टल, वर्टिकल, देन हॉरिजॉन्टल, और फिर सुपरस्टर्नल एरिया में आपने कैलकुलेट करना। जैसे आपकी कंप्लीट थ्रिल आप चेक कर लेंगे सारी।
सर, जब हम पेशेंट को जेवीपी चेक करने के लिए 45 डिग्री पे मतलब थोड़ा सा उठा के रखते हैं, तो क्या उसी पोजीशन पे हमें फिर बाकी मतलब प्रीकॉर्डियम एग्जामिनेशन भी कर लेना है या उसके लिए पेशेंट को फिर?
नहीं नहीं नहीं, अच्छा एक चीज हमेशा एग्जामिनेशन में याद रखनी है कि अगर आप एग्जामिन कर रहे हैं तो पेशेंट को बार बार आपने मूव नहीं करना। आपने ऐसा अपना एग्जामिनेशन को एक सिस्टमेटिक वे में लेके जाना है कि आपने एक ही पोजीशन में सारे कंप्लीट कर दिए एग्जामिनेशन, फिर आपने उसको बिठाया और आपने बैक वाले एग्जामिनेशन कंप्लीट किए, और फिर लास्ट में आपने लिटा के एब्डोमेन और लोअर लिम्ब को कंप्लीट कर दिया, यानी उसको बार बार मूव नहीं करना। तो आपने 45 डिग्री पे जब आपने आइडियली आपका पेशेंट शुरू से ही होना चाहिए और उसी में ही आपने सारे एग्जामिनेशन अपना करना है, और फिर आपने बैक एग्जामिन करने के लिए बस बिठाना है और बाकी आपने सेम पोजीशन में सारे एग्जामिनेशन कंप्लीट करना है।
There's a question in the chat box. Should we check all pulses in short case as well?
जी, पल्स तो लाजमी चेक करें, रेडियल पल्स, रेडियल डिले और रेडियो फेमोरल डिले, क्योंकि अगर कॉक्टेशन हुआ, आपको नहीं पता, आपने एग्जामिनेशन में रेडियो फेमोरल डिले मिस कर दिया, तो आपके पॉइंट मार्क्स नहीं मिलेंगे, आप डायग्नोसिस भी नहीं बना सकेंगे। तो इसलिए पल्स आपने लाजमी चेक करनी है और उसको कंपेयर भी करना है। पल्स इज अ पार्ट ऑफ द। अच्छा, दूसरा ये एक और इम्पोर्टेंट चीज कि डिपेंड करता है आपके एग्जामिनर ने आपको कमांड क्या दी है, कि उसने प्रीकॉर्डियल एग्जामिनेशन की कमांड दी है रेलिवेंट, या फिर कार्डियोवैस्कुलर एग्जामिनेशन की कमांड। अगर प्रीकॉर्डियल एग्जामिनेशन की कमांड है तो फिर आपने एक्सपोज करके इंस्पेक्शन से स्टार्ट करना है, प्रीकॉर्डियल एग्जामिनेशन करना है, और मींस कि आपने प्रीकॉर्डियम को सबसे पहले फोकस करना है, इंस्पेक्शन, पैल्पेशन, ऑस्कल्टेशन, फिर आपने जो है फिर आपने उसकी हैंड पे आना है, पल्सेस देखनी है, जेवीपी देखनी है, हेड पे जाना है, बैक एग्जामिन करना है, और फिर बाकी मैनूवर्स करना है, मैंने बताया। लेकिन अगर सीवियस एग्जामिनेशन है तो फिर आपने डायरेक्ट हैंड से, पल्स से और इससे स्टार्ट करके फिर आपने प्रीकॉर्डिंग पे आना। तो डिपेंड करता है कि आपको कमांड क्या है, लेकिन पल्स एक इम्पॉर्टेंट पार्ट है शॉर्ट सीवियस एग्जामिनेशन।
There's a question on chat box. If the patient is cyanotic, should we check go for radiofemoral delay.
ओके, ये इम्पोर्टेंट क्वेश्चन है और पूछते भी एग्जामिनर, अगर आपने साइनोटिक पेशेंट में रेडियल या रेडियो फेमोरल डिले चेक किया और आपने मेंशन भी किया अपने समराइज वाले पार्ट में कि देयर इज नो रेडियल और रेडियो फेमोरल डिले, तो एग्जामिनर पूछते हैं कि आपने क्यों चेक किया कि आपका साइनोटिक पेशेंट है तो इसमें इसकी क्या रेलेवेंस है। तो आप ऐसे इसको डिफेंड कर सकते हैं अपने पॉइंट को कि मे बी योर पेशेंट इज हैविंग coarctation of aorta along with the tetralogy of Fallot, या फिर एसोसिएटेड जो है aberrant left subclavian artery along with the tetralogy of Fallot. So basically you have to defend your point ना। तो एसोसिएटेड लीजन्स हो सकती हैं, ये जरूरी नहीं साइनोटिक हार्ट डिजीज के साथ कॉक्टेशन नहीं हो सकता या उसके साथ aberrant left subclavian हो सकती, देयर आर देयर इज एसोसिएशन विद, तो आप ऐसे डिफेंड कर सकते हैं।
फर्दर क्वेश्चंस है चैट बॉक्स में। पिंक टॉफ में वीएसजी का मर्मर आ सकता है एंड टॉफ में वीएसजी का मर्मर क्यों नहीं मिलता?
सबसे पहले मैं टॉफ का बताता हूँ। टॉफ के अंदर वीएसडी का मर्मर इसलिए नहीं होता कि इसमें राइट वेंट्रिकल और लेफ्ट वेंट्रिकल के प्रेशर्स इक्वल होते हैं, ठीक है। सिस्टमिक और प्रेशर्स मींस के लेफ्ट वेंट्रिकल के प्रेशर्स और राइट वेंट्रिकल प्रेशर्स इक्वल है, तो मर्मर हमेशा तब आता है जब दो साइड पे डिफरेंस हो इन द प्रेशर्स। तो टर्बुलेंस के साथ जब ब्लड क्रॉस करता है तो उसमें हमें मर्मर मिलता है। तो टॉफ के केस में ऐसा नहीं होता, उसमें दोनों साइड के प्रेशर इक्वल होते हैं, तो वीएसडी के लेवल पे बाय डेफिनेशन शंट होता है, तो देयर इज नो मर्मर। जो उसके अंदर हमें मर्मर मिलता है लेफ्ट वेस्टर्नल बॉर्डर पे एक पेन सिस्टोलिक का, वो बेसिकली ट्राइकस्पिड रिगर्जिटेशन का होता है। तो वो हमें मिसगाइड करता है कि वो वीएसडी है, वो बेसिकली पीआर का मर्मर। इसलिए कभी भी टॉप में हमें तो वीएसडी का मर्मर नहीं पता, वो मैंने आगे एग्जांपल में भी बताया। अच्छा, दूसरा ये कि पिंक टॉफ के अंदर वीएसडी का मर्मर मिल सकता है कि नहीं, डिपेंड करता है सिवियरिटी ऑफ पल्मोनरी स्टेनोसिस पे। आप क्लिनिकली नहीं बता सकते कि इसकी पल्मोनरी स्टेनोसिस की सिवियरिटी कितनी ज़्यादा है। एक क्लू आपको मिल जाता है कि आप पल्मोनरी का जो एरिया में मर्मर है बहुत फेंट सा होगा, बट अगर बहुत फेंट मर्मर है वो आप मिस भी कर सकते हैं। तो बेसिकली आप पिंक टॉफ क्लिनिकली तब बनाएंगे जब आपको पीएस का मर्मर मिलेगा और साथ में वीएसडी का भी क्लियर कट मर्मर मिलेगा हो, वरना आप सिंपल उसको वीएसडी बनाएं या पल्मोनरी स्टेनोसिस बनाएं अलग अलग।
Any other questions? Thank you so much, Dr. Adeel, for a wonderful and very informative lecture. Thank you everyone for joining us. I think there are no more questions and we can end the session. Everyone is kindly fill the survey form. The link is on the chat box. Chat box पे और भी questions are being shared.
First few slides. First few slides were just about the general examination or syndromes, association, pulse, और JVP. अच्छा, हीविंग एक कुछ है एक्सप्लेन का ना, तो हीविंग बेसिकली अब हम यूज नहीं करते, उसकी जगह फोर्सफुल वर्ड यूज करते हैं। फोर्सफुल जैसे मैंने बताया कि इसका मतलब ये है कि आपकी फिंगर लिफ्ट होती है, इफ द एक्सप्लेन इज लिफ्टिंग योर फिंगर, तो बेसिकली फोर्सफुल है। फिर इसमें हम सस्टेन्ड और इनसस्टेन्ड की टर्मिनोलॉजी यूज करते हैं डिपेंडिंग के कितने पोर्शन ऑफ द सिस्टली में आपकी फिंगर लिफ्ट हुई और कितने पोर्शन में, अगर 2/3 से ज़्यादा हुई सिस्टली में तो इट फोर्सफुल और सस्टेन्ड है। अगर 1/3 पोर्शन ऑफ द सिस्टली में सिर्फ लिफ्ट हुई आपकी फिंगर तो इसके फोर्सफुल तो है बट इल सस्टेन्ड। तो फोर्सफुल और इल सस्टेन्ड जो है वो वॉल्यूम लोडेड कंडीशन में मिलता है जैसे MR, AR, और जो फोर्सफुल और सस्टेन्ड है वो हमें प्रेशर ओवरलोड कंडीशन में जैसे एओर्टिक स्टेनोसिस में। डायग्नोस्टिक सिग्निफिकेंस ऑफ रेडिएशन और ट्रांसमिशन, नहीं डायग्नोस्टिक सिग्निफिकेंस नहीं है, बस ये कि जब आप एग्जामिनर को एक्सप्लेन कर रहे हैं अपनी फाइंडिंग्स, उसमें टर्मिनोलॉजी आप करेक्ट यूज करें, ये इसके लिए बताने का मकसद ये। कैन वी कीप पिंक टॉप एज डीटी, किसके डिफरेंशियल में? पिंक टॉप बेसिकली आप क्लिनिकली, जैसे मैंने पहले बताया था, आप इजीली नहीं बता सकते ना, तो आप या तो सिर्फ वीएसडी बोलें, अगर आपको वीएसडी का बारे में मिलता है तो सिंपल आप वीएसडी का डिफरेंशियल बनाएं या डायग्नोसिस बनाएं, और अगर आपको पल्मोनरी स्टेनोसिस का बारे में मिलता है तो आप पल्मोनरी स्टेनोसिस बनाएं, ठीक है। तो आपको पिंक टॉप की टर्मिनोलॉजी क्लिनिकली आप इजीली नहीं बता सकते। आप डिफरेंशियल अगर पूछते जा रहे हैं एग्जामिनर, तो फिर आप थर्ड या फोर्थ पे आप डिफरेंशियल में रख सकते हैं, लेकिन आप फर्स्ट अपना डायग्नोसिस ना बनाए पिंक टॉप शॉर्ट केस। अगर आपको लॉन्ग केस है, इसमें हिस्ट्री भी फेवर कर रही है, फिर आप बना सकते हैं, बट शॉर्ट केस में आप जो है क्लिनिकली नहीं बता सकते, तो फर्स्ट आपका डायग्नोसिस नहीं होगा पिंक टॉप।
I think the questions have finally been answered. Thank you, Dr. Adeel, for answering all the questions. Thank you, everyone, for joining us. We will end the meeting now. Kindly fill the form, survey form. The link is in the chat box. Thank you, everyone.
Thank you so much.